Hello and welcome back to the SimTech podcast. Today we're trying something new. We're bringing you a full simulation scenario and debrief so you can experience the process in real time. In this episode, we'll be exploring a case that challenges participants to demonstrate skillful assertiveness in a clinical setting. So here's the pre-brief. You are a foundation year 2 on an orthopaedics called to review Morgan Harrington, a 20-year-old patient who underwent surgery earlier today for a left tibia fracture following a motorbike accident. Despite receiving analgesia, the nurse has asked to see you because the patient is still complaining of severe pain in their leg. So, how will you handle this situation? What decisions would you make? And most importantly, will you be able to advocate for your patient effectively? Stay tuned as we step into the scenario and break it all down in the end when we have a full debrief discussion. So, let's get started.
One of the nurses.
Hi. Hello, nice to meet you.
Just a bit worried about him with the pain.
Hello, it's Morgan.
Hiya.
Hi. I'm Nathan, one of the doctors that looked after you today.
Great.
This is my colleague, George. Hello. Great. Do you look at the exam?
Yeah, sure.
And I'll just see what's happening.
Yeah,
Any notes?
so I can do the A3 assessment and we can...
Say again, sorry?
Have you got any notation or documentation from
Yeah, just on the notes here on the computer. So it's Morgan.
Thank you. Cheers.
It's just that my legs...
Okay, so I'm one of the nurses. That's it, yeah.
Okay, when it started being painful? After the surgery, just after the surgery. Okay, all right. And do you have any sensation in that leg? Can you move it a bit? Or move the toes?
A bit, but like, all I can feel is pain.
Right, okay. All right. And what kind of surgery did you have?
I don't know, it's just something I've done on my leg.
You had a nail put in.
All right.
For a tib fracture.
Please can I have some morphine? I've given
Do we have any vitals?
Sorry,
Can we get some obs?
Some odds, yeah, that's fine. Yeah,
Do
sort that.
blood pressure, heart rate, SATs.
Sure.
Okay, do you know how much morphine you've received so far?
I'm not sure. I've only just come on shift.
That's fine, yeah.
But I think 5 milligrams.
Okay,
Yeah.
cheers. Thank you.
Okay.
Righty. Have we tried elevating it?
He doesn't let me go near, it's like too painful.
Oh, righty. Okay.
That's
Yeah. Right, can you tell me how you're feeling at the moment?
The pain's unbearable. I mean, absolute agony.
Okay.
Morgan,
So
can I just pop this on your finger?
Yeah, I think just do it, yeah. Okay. Have you started already?
Yeah, so I was just going through a bit of a history taking the okay. So our airways patent, we'll just breathing,
And this on for your blood pressure, Morgan.
saturation's 100% on air. Just have a listen to your chest, okay?
There's some more stuff in here.
Please, can I get some pain relief?
What pain relief has he had?
He's got 5 milligrams of morphine.
He's written up for 10 milligrams here. We could probably give him another 5 milligrams.
Yeah,
if you're happy with that.
Yeah, we can just give him another 5 milligrams. Do we prescribe them the system?
Yes, on the system if that's okay.
No problem. Nathan, do you mind prescribing the 5 milligrams of morphine?
Yeah, he's written up for 10, so I think we could just do that. I'm just going to do it here again, yeah.
So
yeah.
chest is clear.
I think I've got a pen on me.
Let's just do a respiratory rate. Can you just count his respiratory rate?
Yeah, his rest rate was 24.
24.
Yeah.
Okay. All right.
Just checking whether he's got a vent on. No, I'll just get a cannula in.
Okay. Well, we do the cannula. Do we get some blood samples as well?
Yes, sure. What would you like?
So let's just do a general screen. So full blood count using these LFTs. Just do a coag.
FBC, UNEs, LFTs, COAC. Okay, thanks, George.
So I'm just writing up the extra one here.
Okay. So if I just checking your blood pressure. Let's just go move on to C. Okay. So okay, let's have a listen to your heart.
Please, can I get something for the pain? It's unbearable.
Absolutely. We'll just give you the morphine at the moment. We'll just get some IV access, okay? We'll just put a cannula in and then we'll give you some morphine, okay?
in here. All right, Morgan, putting a cannula in for your pain relief,
I reckon
okay?
exactly one. I think we can speak to these surgeons and think about maybe actually that did open up. Let's see if we can open up the task for
please. Take the card.
Okay.
Got to raise blood pressure.
Sure.
Okay.
What do you think about
scratch.
actually opening the cast, having a feel for the pulses?
Yeah. So I think if we're suspecting there's something going on with the operated one, we just need to have a look at it. Yeah.
Just be thinking of the compartment, Okay, so just wear the gloves. Okay.
I don't want to sit like this anymore.
It's all right.
We're just getting the IV access ready, and then we'll be able to give you some pain relief. Okay.
All right. So, Morgan, I'm going to try and unwrap some of this so I can have a better look at your leg, okay?
Please be careful, because I can't.
It doesn't like it when you go near it.
Okay. All right.
I don't know if I can't.
That's fine. Do we have anything we can put underneath the leg? Would you have to just... We can try and elevate your leg. That might help a bit with the pain.
Try and raise the bed.
It's been really sensitive when I've touched it. I mean, that is a good idea. I can go and see if there's another pillow from the next bed.
Sure. Yeah, we can give that a try.
I've got that cannula in. I'm just going to go and get my colleague to check the
thank you so much.
Have you managed to take the blood samples at all?
Yes, I'll send the bloods off as well.
Perfect. Okay.
Christine, can you do a drugs check for me?
Okay. So check your obs again.
Yeah.
Blood pressure is 165/71. Respiratory is going up. Heart rate's up.
Yeah.
Okay. Fine. So I know this is going to be really painful. I'm sorry about that. But we need to have a feel to see if there are pulses in your leg, see if that's all working well. Sorry. Can you feel me touching it here?
Yes.
You can feel that. Can you wiggle your toes to me at all?
I can't. It's way too much.
Okay, fine.
Okay.
What do you think?
Just wait a little bit until the morphine gets in. Yeah. How long would you think would need to wait for the morphine to be given?
Oh, I'll give it now. I've just sent those bloods off and got the drugs checked, but I've got it drawn up.
Okay. So you can wiggle your toes a bit.
Okay.
You can feel where I'm touching.
Yeah. It's just
I haven't had a proper feel of the pulses yet, just with how much pain is in it.
I don't understand why it hurts too much. This much.
like we'll be able to cut the.
Yeah. Let's think about doing that next.
That's what we need to do.
Do we have any of the scissors available?
Scissors, yeah. I'm not sure where they are.
No. Okay.
Are they in top drawer here?
Might be. I'm not too sure myself.
Oh, yeah.
Oh, lovely. Thank you.
Right.
Okay. Well, I'm not going to touch your leg. Yeah. I'm just going to be cutting on the bandages on top to see if we can get a better look at it, okay?
Okay. I know it's very difficult at the moment.
You just give me all right. I'm going to give you some medication.
Please. Ow!
I've not touched it.
Please, I can't.
Yeah,
It's fine. I'm sorry.
No, I understand.
It's Kate. We're looking after you. Can I give you this morphine?
Oh, please do.
Yeah, just give me your arm and I'll put it through.
So look at the obs again.
I've never felt anything like this before.
I'll see if I can find a note or anything. See
Give me that pain relief, Morgan, okay? Stick with us.
Okay.
No. They didn't really mention anything. They just said, be careful of the compartment syndrome and obviously trying to keep it elevated.
Okay. All right. How are you feeling after the morphine? Has that helped at all?
I'm still in agony, but I'll give it a second.
Okay. Do you think let's try and
let's give it a try.
We're going to try and cut the cast at the moment so we can have a better look at your leg, okay?
I'm sorry. I can't. I really can't.
Okay.
We're just going to have to get it off anyway.
Yeah.
I can't. Please!
I can feel it.
Please, oh God, I can't.
What do you think?
I think we just need to notify.
We'll speak to the surgeon. Know what's been happening.
I need some more morphine. If you've got anything stronger, please.
Just giving him 10.
Yeah.
I think we need escalators to see.
Yeah, we'll speak to the senior now. We'll hold off the extra morphine in a moment. Okay. Yeah. It's just 0.
So the switchboard, I think it's just 0. Oh, redial. Let's redial.
Yeah.
There you go.
Hello, simulation switchboard.
Hello, could you put me through to the orthopaedic reg?
Orthopaedic registrar, one moment, please.
Yes, thank you very much.
Hi, it's Mr. Dan Stevens, the orthopaedic CT1. I'm covering the reg beat while I'm in teaching. Can I help?
Hi, I'm Nathan, one of the doctors covering orthopaedic wards at the moment. There's a chap who you operated on today, Morgan Harrington.
Oh, my boy Morgs.
Yeah, he's a chap that is, he had a left intramedullary nail foot and left spiral tibia fracture.
Yeah, I did it. It was a pristine bit of operating, to be honest with you. It's probably one of the best IM nails I've ever done.
Right. He's in quite a lot of pain at the moment. We've given him around 10 to 15 milligrams of morphine. I've had a quick feel of his legs. It looks like he's able to move his toes a bit, and I can feel a pulse. He can feel where I'm touching, but he's in a lot of pain. I think they're just thinking about compartment syndrome, just trying to be a bit wary of that.
I do not just need to have his leg elevated and some morphine.
So we've tried the morphine. It doesn't seem to be helping too much. He's in too much pain for me to even try and lift his leg. Obviously, I'll try to do that with a pillow afterwards.
All right, okay. I'm holding the bleep, so I'll come down and have a look.
Perfect. Thank you very much.
Grand. I'll see you shortly.
Thank you.
I want to be put under and then they can do it and touch it. I don't want to be conscious when they're doing it. I can't.
Okay. My colleague is coming with the advice.
He's going to come round and see him fairly shortly. It wasn't a consultant, it was one of the CT ones. He's covering the bleep at the moment. He's going to come round and see the patient very shortly. We're going to try and elevate the leg.
Induction, tail fixation. Hi, Morgs, how are you?
Oh, no good.
What's going on, then?
Ever since the surgery, I can't do it anymore.
You look like this. Have you guys given some pain?
Yeah, we've given him some.
You just have 10 milligrams of
Just had 10
morphine.
milligrams of morphine.
What's going on? You think where's the pain, mate?
My leg.
All right. I mean, the operation went really well.
I'm sorry.
Well,
He's in very severe pain.
I mean, we should probably have a look at it, shouldn't we?
Please don't touch it, please.
Well, I'm going to be really gentle. I'm just going to trim this off, okay?
Please, no, stop!
I'm not really...
Stop!
I'm not...
Please, no, stop! Please, stop! I don't want you to do this anymore, stop!
Morgan, I've stopped now, but what we need to do is we need to take the cast off so we can have a look at your thigh and your calves so we can make sure that the wound's okay. It's well over half done. Can I keep
Please, no, stop!
There we go. Is that really sore?
No, please don't touch it!
If I move your toe like that, I think. Can you guys give me some more coffee?
Yeah.
What's he doing?
He's gonna go sort out. I think he might want to bring it down to theatre again. We're gonna give him some more morphine just to try and keep the assessment.
Okay.
Okay.
Can you prescribe the
Yeah, we'll prescribe the extra ones.
Right,
Yeah.
so what we need to do is a ward-based opportunity here, which is really important. It's compartment syndrome.
What did you say, sorry?
We're doing a ward-based opportunity because we need
I'm just prescribing the morphine, okay?
Okay, what do you need me to do?
So what I need to do is I'm going to put that gown on in a second. We need you to tie me up.
Okay.
And what we'll do is I'll just get the stuff ready. We're going to make a fasciotomy curve down on the side of the
Let's look for the
stroke.
prescribed
And get some balls down here.
Yeah.
I'm going to tie my hands. Sorry, Morgan, we just need to crack on and do this, mate.
I think you need to.
You need to time it, please.
I thought it was just what's with all this?
Can you pass me the other side?
What?
Just pull it. Put it in tight. I haven't got time. Let's go. I can't believe you guys have left it this long. Right, so Morgan, what we need to do is do a big cut down the side of your legs here.
What?
You've got too much pressure in your calf.
No.
No. I need to do any sedation first.
Do you think maybe we should speak to the consultant?
They're in the operating room.
No!
This is all breathing fear, the register and teaching, this just needs to...
Are you super sure he's got compartment syndrome?
Yeah, I mean, look, he's got, whenever he passively flex his toe, it's excruciating out, he's got pain out of proportion, not touched by morphine. I can't feel a pulse, his compartments are really tight, we just need to crack on.
I haven't seen this on a ward before, and I've been working here for a lot of years. I've just wondered if it's the right thing to do.
We should So I think we need to...
What?
And I need to...
I think we need to speak to the consultant here.
It's not very slow.
Yeah, so I think we need to speak to the consultant.
We need to speak to the consultant
It's
here.
like,
What's in I need this to happen now. I need it for my logbook. He needs his leg savings, otherwise he's going to lose his leg. If he loses his leg after this, you're going to get sued, you're going to get sued, you're going to get sued.
Okay.
This is completely unacceptable. Like, I'm a CT1, I've got my NRCS, we just need to go and do this.
Okay. Our nursing staff are very concerned about this case, obviously. I think there's some concern we're not doing the right thing here.
Let him finish.
I think they're concerned we're not doing the right thing
Don't
here
speak to
for
me
him.
like that.
How about you just crack on and keep
No, I'm staying here with my patient.
So we're going to speak to the consultant first. No, we're not going to go ahead with this. Let's speak to the consultant.
I think this is really unsafe. You need to stop now.
So mate, there's going to be a
Stop. I think this is really unsafe. Stop.
We'll speak to the consultant.
I think this is really unsafe. We're not doing it with a proper procedure. We haven't done any checklists. This is a medical procedure. We need to be sure that we do all the steps
I
accurately.
think you just need to...
Can you give me the scalpel, please?
This is a gentleman that's in a lot of pain at the moment, but we cannot manage it. And you're trying to open up.
It's not safe to do
You're not doing this
this.
under sterile. You've not spoken to your consultant, and you're just trying to do this on the ward now.
Training this place. I'm sick of it. What's wrong with you guys? It just needs a
We're just trying to be safe for the patient.
some more morphine, please.
Yeah.
Ow. I reckon so. So I see you've been practicing.
You have to have a standing ovation for the others. That was so good. That was fun. Oh my goodness. I think Blake deserves an award for that.
Pay rise.
Yeah.
Is that based off a real scenario?
Yes.
Oh, what?
Yeah.
Where?
You were expecting Zorro.
Give us the details.
Oh, I've had an accident. Where am I going to... Where are we taking you? Oh, we're going... I'm not going there.
Alright. Okay. So you know what's going on. Just get a few things in the report. Okay.
I think you guys took appropriate to management to try KV first when it didn't work. Considered other things like compartment syndrome. And I think you worked together well as a team.
You worked well under pressure. That is the loudest I've heard someone scream from a medical point of view.
I was so scared.
Yeah, like to actually work under that environment must be so tough. But ours was silent.
Yeah, but you came in, there was like this massive hosing of blood.
Yeah, but I imagine even just trying to gather your thoughts though, there must be so tough, I think.
I think you made the hard call to tell the CT1 not to do what he was trying to do.
Yeah.
To make it difficult, especially
I was more than happy for to come in to see the patient. I didn't expect him to alright, knife. It was a logbook.
I think in these situations it's really difficult to justify why you think that doing this is wrong, but you know it's wrong. You just can't find the words because of the situation.
Well, the second he was like, "Oh, I'm not gonna wash my hands for this," I was like, "What?"
Yes, you are.
Did he say I'm not going to wash my hands?
He's like, "Oh, we don't have the time. I'm not gonna wash my hands," and I was like,
You say the difficult senior, given all of these things that you're.
I think they like stood for the decision that they made, and they were like ready to compromise even after the CT1 said, "I'm going to sue you," or "you're going to get sued," and Kay's going to get sued, and stuff.
That's really scary.
Which is actually quite scary.
So scary. If I hear I'm going to get sued.
You go ahead.
Okay, go on. Plan around.
Georgie, I've seen them.
Go away.
You're going to take that. Yeah.
I thought for the good side, despite the fact that I think quite early on it seemed like there might be a sort of probable compartment syndrome, still looked at the whole patient and sort of looked for other causes rather than just going down a rabbit hole.
I feel like he works well with the nurse as well, especially when she's being shouted about Ollie. You kind of stood up for her as well, which is
I just didn't expect him to go all out with that acting. I thought he would have like.
Expected it from the screen, like, they're all.
It's true.
Yeah, true.
Good tool, it's great.
Okay. A few things on there. Let's see. I think worked well. Under pressure, like gathering thoughts, but also there's something here about all that stuff about dealing with the difficult senior. Okay. You've got a number of things really making it hard for you to proceed there, haven't you? All right. So, has any of you had to stand up to a senior colleague?
Not that directly.
Not that directly?
I tried once.
Okay, right.
But I kind of just got shut down.
Really?
And then when he left, his decision was overturned.
Oh, right.
So
shit. Where's this?
Durham. It's basically a patient who's in type 2 respiratory failure who put NIV on, and then the consultant came and said, "Oh, I don't think they need NIV. The gas doesn't look too bad." To which everyone was like, "Are you sure?" And obviously he was a consultant, so he took it off, challenged him, and he said, I can't remember his exact words, but he basically said, in a nice way, don't try to undermine that decision. And then the reg, he was a respiratory reg, came on overnight, which is about half an hour later, and then put him back on.
Anybody else got any examples?
I sort of argued with the consultant about whether to treat someone as a paranoid schizophrenic or encephalitis. I felt it was textbook like paranoid schizophrenia, but the consultant was like assured it was paranoid encephalitis when the outcome was negative. And essentially, she delayed transferring to Manchester for like 4 or 5 days because Manchester couldn't give IV antibiotics, which she was adamant the patient needed, but I just spoke to the site consultant, they were like, "Yeah, we'll kind of just take off antibiotics and take the patient too." It was very like weird to like say it and the consultant in the middle of to go, "Yeah, I don't really agree with you, so we need this." It just felt a bit like, "Oh, okay." Yeah.
Okay. Anyone else?
I don't know that I remember the name. The Bob was working, we were dealing with a patient had severe learning difficulties. We became very confused, agitated, getting up to bed, we needed to go sick to a lot of things. She needed, what's it called? Like diazepam. And sedation for agitation, being kind of aggressive stuff, things like that. And we've given her a lot. So at some point when we've reached the point of what we can deal with the work, I spoke to anesthetics, and anesthetics said that if you cannot handle with her agitation on a work level, she would need the admission to ITU and then kind of sedation by the ITU team and things like that. And I mentioned that to the consultant, and it just said, no, I think it's fine, people can get agitated, that's all. Okay, just leave it as it is, but the patient kept getting more and more agitated, and I explained to them the plan kind of multiple times, but I wasn't able to change the decision to the consultant. And I think I brought the anesthetics reps that I spoke to the department where they were working to discuss that as well, and they said that they didn't think that we would be doing anything with that, with regards to that. And then the next day when I got back to worksheet I had to, because it was a different consultant, they said, why didn't we do it sooner? It was a very urgent thing to do in the morning, because she needed a lot of sedation. She went to ITU and stayed there for a week, went out, came back again, I think after that she died. But yeah, it was very difficult to deal with on the daytime.
Interesting. So it's difficult, isn't it? Because you give a couple of examples there, haven't you, of just, well, look, I tried to argue the rationale and then they weren't having it. And it's hard. And then it becomes obvious, somebody else steps in, which was the theme of a couple of these, where somebody else steps in, and just, it's obviously it's the wrong decision and takes over. Now, I'm gonna kind of put my cards on the table here and say, I think you're all nice people, and I'm also going to say that you're all smart people. So my thoughts are that we all tend to come to work to try and do good things, and that's my default. Is I assume everybody's coming from a good position. Yeah. So if somebody comes into you like that, making what is clearly a bad decision. What makes people make bad decisions like this?
Stress.
Because they're smart, right?
I think ego is what I see most commonly. Once people have made a decision, they don't want to reverse on that because they're wrong and it affects their ego.
So there's an ego thing. So there's some personal qualities there that might come into play. Yeah. I certainly think that I've seen some examples of that myself. Would you agree with that?
Yeah.
Anything else that comes into play, do you think?
Stress and a curative situation, specifically in this case. There's a fairly clear management plan, but obviously clouded by that, and seems very this needs to happen now rather than sort of taking a moment and analysing.
Yeah. What's the stresses in this situation?
The noise.
Noise is definitely one of them.
The acuity of the situation.
Yeah, urgency. Because how long have you got with a leg that's compartment syndrome?
Not long.
I mean, maximum 6 hours, but really, majority of the time, can go a lot sooner. And if you're at the point where it's starting to go pale and your pulses are starting to go, you don't know what at all. You're already too late. So yeah, you're right. There's a lot riding on that. And then I suppose there's other things that you might not think about. I mean, what other sorts of pressures could be going on in the background? Any ideas? Any thoughts? Any guesses?
Your rash could be in the theatre. I was in this scenario when I was in orthopaedics. We had a lady on the ward who didn't have a fracture. I can't remember why we thought we had compartment syndrome. It was basically you could hear from down the corridor, and we tried everything. And we tried to pump so much morphine into her, and she was still in so much pain. And so we were like, okay, we think it is compartment syndrome. But the reg was in theatre, and as the junior, trying to convince your reg over the phone that even someone who's never seen compartment syndrome before, I'm telling him that I think it is. So to convince him to try and come out of theatre. He came and looked at it, and he was like, no, she's not in enough pain. And you're like, so how much pain is enough pain? Because you haven't seen it before too. And it was it was difficult because he stood there a while, and then he finally gathered his thoughts, and he was then he brought the consultant in, and they discussed together. It was there was a lot of discussion and a lot of convincing and talking.
What is enough pain with compartment syndrome? Anybody seen compartment syndrome? I think. Aside from anyone else seen it?
Been a few queries, but they've always been able to mobilise the leg. You could feel the pulse and stuff, so it's not really convincing clear cut.
Yeah.
I think there was a case we saw. It was a case in AMU where a patient had come in who probably needed compartment syndrome and didn't, and then clearly, the limb was lost essentially.
Yeah. The only ones I've seen is big arg. Various states of arg, basically. It is generally out of proportion pain to what you should be expecting, isn't it? Really. Do you know how do you know if it's definitely compartment syndrome or what clinches it, generally speaking? Have you seen when they do that with the toe?
Pain on active passive flexion.
Yeah, absolutely. Yeah. So you do that, and it's pretty much it's very high chance that that's what you're doing. So okay. So what's the priorities in this situation? So you go in there, you've got this cast on, you go out of the toilet, crap. I think maybe what's it going? What's your priorities?
Split the cast.
Split the cast, yeah. Is that enough?
Well, I guess in this case, because we didn't know exactly what we were dealing with, was just one trying to get to more settled pain relief, that kind of thing.
And then pain relief, yeah.
And then afterwards was trying to assess the scenario, see if it was compartment syndrome or not. So we tried to kind of open a bit more, but obviously wasn't having it. It was quite difficult. So I probably should have just continued, but I just heard so much screaming, and I just thought I could stop.
Yeah. Messes with your head when you're in that situation. You're absolutely right. You're absolutely
We're doing something wrong.
I in my head I should continue this, but at the same time, the guy's screaming so much, I'm just doubting it.
Yeah. I've seen like a couple of crush injuries like that where there's just screaming the place down and you can't concentrate because they just won't shut up. And it's like, So, pain management, okay. Cast, you're definitely right, crack it, that's great, and you absolutely need to do that. Can you leave once you've cracked it, do you just leave the cast there?
Get off.
Why is getting the cast away important?
Because any kind of additional external pressure is going to increase the pressure in the compartment, so you need to get it away.
Yeah. Because even if the posterior, you could argue what if it's the posterior compartment when it's being compressed. But even if it isn't the posterior compartment, the back of the calf's pushing the back of the plaster's pushing the calf up and putting pressure on the other compartments, isn't it? So either way, it needs to come out of the way. Okay. So, right. So we understand that this person is in this tunnel vision zone where they're making poor decisions. You're there, you can see the reality of the situation. What's the risks? Let's say they're a senior. We don't know if this is what you do or not. Okay, we'll come to that in a minute. But what's the risks, do you think, of flaying somebody open like this on a walk?
Infection risk is quite.
Infection?
Given he didn't wash his hands and stuff as well.
Yeah.
I mean, the possibility of them deteriorating and not being in the appropriate place.
Yeah, it's not as if you can just show them straight on stick a tube down the throat and put them on a ventilator dead easy.
Proper infrastructure to do anything else really doesn't go wrong.
Yeah, so like cauterization, for example, it's not as if you've got access to that. Yeah? Or it's not as if you've even got, you can't put a big rubber band up the leg and stop the blood flow, you can't do any of that. So, it's just not the right environment. Would you think in good conscience the patient could consent to that?
No.
Because the risks would be, because we're another kid. You can't really consent a patient in that kind of scenario. Has anybody seen weird stuff done to patients in areas where they're normally not?
I've heard, there's some things I didn't know was common. I've heard in cardiothoracics, they might sometimes have to just open them up on a ward and stuff, and that's apparently quite common.
Yeah.
So.
Yeah.
Obviously,
my brother worked in cardiothoracic ICU in Auckland in New Zealand, and he had to do that a few times.
Yeah.
They said it was the way to say it well.
If you listen to it the first time, you're like, is that safe? They're literally doing open heart operations in the middle of the bay, and you're like, oh, okay. But apparently they just do that.
But it's protocolized, isn't it? It's part of its procedure. The only thing I can think of that I've experienced of that's a bit wild was I used to manage ICU, and one day we had this patient. His gut wasn't he needed a large amount of his gut excised. He was bad away, and he needed surgery. He was going to die. It was as simple as that. You have surgery or you die. But he was on quad strength inotropes. Every time we tried to move him, his blood pressure would just sink. And it was just like, we can't even get him to the theatre, he'll just die on the way. We need to do something really. And it's one of the most unstable patients I've ever seen. And they made a decision that they were going to do open abdominal surgery in the side ward. But it was one of those, you know, where we've got our air supply and everything inside. And I just felt like my hair got slightly grey. Like, honestly, you know, like in the horror movies where my hair goes white. And I was like, what do I do what? But when you look at who was involved, you know, you had like hospital managers, you had like site manager, you had like a surgical lead, like literally everybody who was anybody who were sane no matter was involved to say, well, we do that or he dies, you know, so as it happens, he lasted a few days, but you know, he had his shot.
Yeah.
But it was so weird seeing all the stuff brought in from theatre and the doors literally being taped shut.
It's like when you see something out of protocol like that, you'd think to question it and be like, we're doing the right thing.
Yeah, which obviously.
But obviously in that scenario you had the right people making those decisions.
And that's the difference with this scenario, isn't it? Because in this scenario you had Lone Ranger jumping off his horse and having a slash. It was just madness. So you need to stand your ground, which you did, of course. What was it that they did well when they stood their ground there?
I think they gave him sort of multiple opportunities to back down, and then when that wasn't happening, sort of went over his head and said, we're going to speak to your consultant. Yeah, I think the rough interaction beyond the screaming and the chanting.
So what sort of things did you say to kind of try and rationalise why this was a bad idea?
I think I said, obviously the nurse over here is quite senior, is justifiably worried about what you're trying to do. You've got to discuss with a consultant, and I said, are you sure this is syndrome or not? Kind of just shouted back and was like, okay. And I was like, yeah.
Okay. We try to escalate it appropriately with trying to stop, because there is a specific system, there is what it's called, and we said, you know, I'm sure this is the case, I'm certain that's the...
I was positive that's what you were doing.
Yeah.
I thought, I think he's using cuss here, because I could hear you using the terminology. Were you aware of what he's referring to?
No.
So it's like, it comes from neurolinguistics. The idea is to say that I think, right? Because it's just because anything else seems a bit facetious or a bit patronising, isn't it? So this is just my opinion, I think. And of course, you keep it civil, you keep it professional, you know, because at the end of the day, you've got to work with people, you don't burn any bridges. But you start with, look, I'm concerned. So what's your concerns? What would be your major concern that you could float at the start here with this patient?
It's not the right environment.
This is the right environment, okay. So he turns around and goes, well, I agree with you, normally wouldn't be, but under the circumstances, I think we have to move forward. So where do you go logically would be your next phase of your argument in terms of logic?
Patient's consent.
Yeah, you hit him with everything else.
Yeah.
Absolutely. You just say, look, well, we've talked about this, you're still not convinced, but, you know, I'm still not sure that this is the right course of action, or because it would be uncertain. I'm still unsure this is the right course of action because also there's this. They still progress, and then you said, I think it was, I think we're about like close towards the end of the scenario. I think somebody said, I can't remember who it was, I'm not sure if it was yourself, somebody said that this is not safe.
I think the nurse said.
Yeah, I think the nurse said, because you're surfacing that at that point, because most people would stop at that point, wouldn't they, and say, it doesn't feel safe. And then if they don't agree with you at that point, then you just stop. And you ask them to stop. But also, in this case, you need to physically stop because it's going to result in some kind of abuse to the patient that is literally going to cause the patient who hasn't consented. So you physically go in and stop. Now that's easier said than done, and I appreciate that. But you know, you got to remember, if you go to a court of law, and I've represented the, you know, a couple of occasions. Okay, when you stand up in a court of law, they put somebody next to you who was classed as an expert witness, who was reasonably expert, same level as you, and they'll say to them, what would you do in that situation? And they'll go, there's no way I'd let him cut that leg. And they'll say to you, why did you let him cut the leg? Because he's more senior than me, so you know, difficult though, but you know, this is what you're looking at, isn't it? So, and I suppose it gets more complicated because what if that's your educational supervisor? Isn't that, all the implications that go with it. I'm not saying it's easy. But there are tools there to help you. If that isn't helping, who else is around you that could help you?
Nursing staff.
Nursing staff or senior nurses. I mean, the sort of ward seniors are quite good to back you up.
You'll tend to know what's happening, like what is normal to happen on the ward, like you mentioned as well. So if you don't know,
and you already mentioned you've got the mention consult and things like the acute intervention team as well. So these are quite good. So, in terms of taking practice messages, then. I'm just trying to do the colours. What can we put off on that?
How to try and de-escalate things starting from I'm concerned.
Sorry, say again.
How to try and de-escalate situations starting from like rationalising and using other steps if needed.
De-escalate. It's garbage. Yeah, it's rubbish, isn't it?